Um, from a physiology standpoint, today's lab, there is not a lot of physiology information. Most of what today's lab is going to be is I'm going to go through the bones of the axial skeleton. We're going to talk about the bones. We're going to talk about where they're located, that type of thing. But we do have just a little bit of physiology to talk about. Some of it's going to be centered around the joints, and then some of it will be centered around some of the structures that we find in the axial skeleton. So as far as the joints are concerned, we have two different ways that we can classify joints. One is from a functional standpoint, and again, the other is from a structural standpoint. So this relationship of structure and function that we've kind of seen all semester, continues on through this part of the skeletal system. And that's what we consider the joints, as part of the skeletal, or part of the musculoskeletal system, which is why we study them in this with this exam. From a functional classification, we can refer to joints as one of three different ways. We can say that the joints are either synarthritic, okay, synarthrosis. We can say that they're amphiarthritic or amphiarthrosis, or we can say that they're diarthritic or diarthrosis. Diarthrosis just describes the joint as what that joint is, and diarthritic is describing it from like an adjective standpoint. A synarthritic joint is an immovable joint. Okay, that means that we cannot create any freely movable motion associated with the joint between those two bones. An amphiarthrosis is a slightly movable joint. Okay, and a diarthrosis is a freely movable joint. So when we talk about the functional classification, basically what we're using is how much movement do we get within this joint. And when we talk about a joint specifically, we're talking about where two bones come together. We're not talking about multiple bones. We're just talking about where two bones are going to come together. Now, from a structural standpoint, these joints can be classified as either fibrous, as cartilaginous, or as synovial joints. And these structural classifications actually match up almost identically with the functional classification, their functional classification counterpart. All right, fibrous joints. Okay, these are going to not have a synovial cavity. We're going to use dense, irregular connective tissue to help connect these bones together. And because there is no space really between the bones, and we're using a dense, irregular connective tissue to attach them, there is going to be very little to no mobility between these joints. So for the most part, your fibrous joints are your synarthritic joints. So examples of fibrous joints would be things like the suture joints that we'll see in the skull, right? These bones of the skull are not fused together. They're held together by dense, irregular connective tissue. A syndesmosis, okay? A syndesmosis is an amphiarthritic joint. This would be like what we see at the anterior tibiofibular ligament, okay, which is going to be found down at the distal end of the tibia and fibula, meaning that there is the possibility for some movement, but there's not going to be a lot of movement between those bones. The joints between the teeth and the alveolar socket, that's another example of a syndesmosis, where we can get movement, right? But it's not likely that we're going to get a lot of movement. We know that we can move the teeth. When you go to an orthodontist, you pay them thousands of dollars to move your teeth. So we know that there is movement possible, but there's just not free movement, meaning that we're not contracting a muscle to make that thing, to make it actually move. And then we have interosseous membranes. These interosseous membranes are also amphiarthrosis joints. And these interosseous membranes are going to exist between some of the long bones in the extremities. From the knee to the ankle, we have the tibia and the fibula next to each other. And they're not just kind of hanging there next to each other. There's going to be a membrane that lines and connects the lateral and medial aspect of one to the other. The same thing is going to be between the radius and the ulna. So we're not actually seeing a ton of movement between those bones like that, but it is basically helping us to provide us some stability between those two bones. That's the thing about joints, all right, is that we're going to talk about stability versus mobility. And when we see stability go up, we're going to see mobility go down. And when we see mobility go up, we're going to see stability go down. All right, it's an inverse relationship that we see with between those two things. Cartilaginous joints. Cartilaginous joints can be either synarthritic or amphiarthritic. It just depends on which cartilaginous joints we're talking about. One cartilaginous joint that we've already mentioned is the epiphyseal growth plate. I mean, technically that is a joint because we're attaching the epiphysis onto the underlying diaphysis. There is no motion there between those two bones, but because there is a cartilaginous or a piece of cartilage between those two bones, we can classify it technically as a cartilaginous joint. Now, obviously, those joints are going to go away once we reach skeletal maturity. The other type of cartilaginous joints that we see would be things like the intervertebral discs. So between the vertebral body in the vertebral bodies in the spinal column, those would be considered amphiarthritic joints. Between the pubic bones, okay, where the pubis bones come together in the pelvic girdle, that would be considered a cartilaginous joint and an amphiarthritic joint. So those would be examples of those cartilaginous joints. And then we have synovial joints. And synovial joints are going to be joints that are going to be made up of synovial capsules. We talked about synovial membranes when we talked about different types of tissues. This is where we're going to find these synovial membranes. And the synovial membranes are going to be contained within what we call the articular capsule, okay, or the joint capsule. Okay, remember where two bones come together is called an articulation. So we're going to have a capsule that's going to surround that. And it basically is going to be a continuation of the periosteum that we find that is around the actual bone itself. Now, inside of that joint capsule, we're going to find things like ligaments. Those ligaments are going to be specifically designed to hold the bones together because we're going to have space between these bones. And the reason we have space between these bones is to allow those bones to freely move against each other. So these synovial joints would be examples of our diarthritic or diarthrosis joints. Okay, these are going to be our freely movable joints. This is where we'll find our synovial fluid produced by the synovial membranes. That synovial fluid, remember, is designed to help to provide nutrients and get rid of waste products to the articular cartilage that we find on the ends of those long bones. But it's also there to help provide lubrication to prevent any wearing, okay, of the articular cartilage as those bones move back and forth on each other. Because we're talking about freely movable joints, we are going to see some friction between those bones. So we want to reduce that as much as possible, which is why we have one, the articular cartilage, and two, the synovial fluid. The next little bit of information right here is just examples of different types of motion that we find within synovial joints. We have a certain list of angular movements right here, okay, that you should know these different angular movements, right? Because when we talk about the muscles, we're going to talk about actions, okay? And action is the movement that is performed by a particular muscle. So we're going to talk about individual movements that are created by muscles. So you need to know these different angular movements. And then you should also know these rotational and special movements as well, right? So the definition for flexion and extension and hyperextension and circumduction, adduction, abduction. Notice I said AD and AB. Adduction is how it's actually pronounced, and abduction is how that's actually pronounced. But because they sound so similar to each other, I just, when I was in practice and in school, I got in the habit of saying adduction versus abduction. Flexion is any decrease in an angle between two bones of a joint. So if you're in an anatomical position and you decrease the angle, okay, meaning if you go from 180 degrees to 90 degrees, okay, that's how we're measuring the angles in these joints, is in degrees of a circle, right? So if I go from 180 degrees to 90 degrees, that's an example of flexion. If I go from 90 degrees to 180 degrees, that's an example of extension. And hyperextension is just any exaggeration of extension past the normal plane. So for example, if my hand and my fingers, okay, are in a straight line, that would be our normal plane, okay? Flexion would be this way, extension would be this way, but then hyperextension would be back past the normal range of motion. So that would be considered hyperextension there. Circumduction, this is when you take the distal end of a body part and move it in a circle, all right? So circumduction of your arm would be movement of your arm like this, okay? That is circumduction. Adduction, abduction. We'll do abduction first because when you abduct someone, you take them away. So abduction is movement of a body part away from the midline. Okay, so if I'm in anatomical position and I move my arm up like this, I'm moving it away from the midline. That would be abduction. When I move it back towards the midline, okay, I'm adding it back to my body. That would be adduction or adduction. Now, rotation. Rotation is when a bone revolves around its own longitudinal axis. Now, we only have a very few number of bones that actually perform rotation. One of them is the radius, okay? Remember, the radius runs down the thumb side of our forearm, and the radial head is going to sit in the radial notch of the ulna. When the radius rotates around itself, okay, like it does when we pronate and supinate, okay, that is rotation of the ulna, okay? So that rotation that we see right there can be considered pronation and supination. Another spot we see rotation is between C1 and C2. C1 sits on top of C2, and C1 and C2 are going to rotate on top of each other, okay? Or C1 is going to rotate around C2. Now, medial rotation and lateral rotation, they are specific to the type of rotation we get in the humerus and in the femur, okay? Lateral rotation is rotation of it away from the body, all right? So if I was to sit like this, all right, and I was to rotate my arm out like that while my humerus is straight down the side of my body, the humerus itself is rotating laterally. When I rotate it back this way, the humerus is then rotating medially because it's rotating towards the midline of the body. And then we have a few special movements down here listed at the bottom, protraction and retraction. Protraction and retraction are movement of a body part either anteriorly or posteriorly in a transverse plane. So protraction would be like when we jut our jaw forward, and retraction would be moving our jaw back to its original position. We talked about pronation and supination, okay? That has to do with the position of the hand, okay? We know that when we're supinated, right, that we're palms up. So supination is the palm facing forward, where pronation is the palm facing backwards, okay, if we're in anatomical position. Depression, elevation, depression, movement of a body part or down or inferiorly, and then elevation, movement of a body part up or superiorly. That should say inferiorly, not interiorly. I need to make a note of that. Hold on, y'all. I'm trying to catch mistakes so we can fix those. So what can we depress and elevate? Well, typically when we talk about the jaw, okay, when we talk about the mandible, that's an example of depression when we lower the jaw, and elevation when we raise the jaw. Eversion and inversion, those are related to the foot, okay, and the position of the foot as it relates to the rest of the body. Eversion is when you take the bottom of your foot or the plantar surface of your foot and you move it outward. Whereas inversion is taking the plantar surface of your foot and rolling it inward. And then dorsiflexion and plantar flexion are also related to the foot. Dorsiflexion is movement of the foot towards the dorsum of the foot, which is the top. So that would be pointing your toes up, or as I like to put it, standing on your heels. And then plantar flexion would be pointing your toes down or standing on your toes. All right. Any questions about those parts of the joint, structures of the joint, functions of the joint? Some examples of some of the joints that we will see. We will talk obviously, and we will identify all of the suture joints in the skull. The pubic symphysis, we talked about where that was found. The sternocostal joints, that's going to be the cartilaginous attachments of the ribs that we'll see when we do the sternum itself. The temporomandibular joint, you won't have to identify that, but you should know the temporomandibular joint, okay, that is your jaw joint right here. So that's the joint involved in protraction and retraction, elevation and depression. Glenohumeral joint, that's our shoulder joint. The radio-ulnar joint. The talocrural joint, that's our ankle. The coxal joint, which is our hip, okay? Again, with the hip, you're going to have to be able to identify these external ligaments, which is what I was talking about in the video that Dr. Rosenzweig made. She identifies these external ligaments. You won't see an internal view, okay? But you should know the different parts that you have on the internal view. And then the tibiofemoral joint, or the knee joint. We will identify all of these structures on the tibiofemoral joint. All right, so let's hop over then to exercise 6. Now, like I said, most of today is going to revolve around identification. The only real physiology that we have to talk about today is a little bit of information about the suture joints and knowing where they are, the paranasal sinuses, and then we'll talk about what the fontanelles are and why they are there. So when we talked about joints, we mentioned having fibrous suture joints, which were going to hold the bones of the skull together. These suture joints, again, are immovable, okay, so they're synarthritic joints, and we're going to have 4 basic suture joints that we find on the skull. The first 2 are actually named after the planes in which these suture joints run. So if you remember your body planes, okay, we had a plane that divided the body into front and back, all right, and we said that was called a frontal or a coronal plane. Well, we're going to find a coronal suture, and the coronal suture is going to separate the frontal bone from the 2 parietal bones. So it's going to run across like this in the coronal plane. The sagittal plane, we said, divided left and right, so we're going to see a sagittal suture that does the same thing. The sagittal suture is going to kind of run down the midline-ish, and it's going to separate our 2 parietal bones. The lambdoid suture. The lambdoid suture is going to be found in the posterior/inferior part of the skull. It is shaped like an upside down V, okay, which is very similar to the Greek letter lambda. Let's hope we don't get to Hurricane Lambda this year. That would not be good. But it's shaped like the Greek letter lambda, which you can kind of see is kind of an upside down V. And the lambdoid suture is going to separate our 2 parietal bones from the occipital bone. And then lastly, we have 2 squamous sutures. And the squamous sutures are going to be located on the lateral parts of the skull, and they're going to separate the parietal bones from the temporal bones. And when I say separate, I know it says join, but basically I'm giving you, it's the line of demarcation. So that's why when you look at the skull, you'll see a bone here, and the suture joint is kind of giving you that separation between those 2 bones, okay? But it's actually joining them together. All right, so we have 3 cranial bones, which are going to have sinuses found in them, and 2 facial bones. The frontal, the sphenoid, and the ethmoid bone. Those are all cranial bones that are going to have paranasal sinuses found in them. And the paranasal sinuses are the sinuses that we refer to when we talk about having sinuses. These sinuses are going to develop as the cranium and the facial bones get larger. Okay, so we don't see paranasal sinuses early on in development. They start to develop during adolescence when we hit puberty, and they're going to do a few things for us. One, by having these sinuses start to form and develop, as we continue to get larger, it's going to not allow for our cranium and our head to get much heavier. It creates some open spaces within the bones without having it be solid mass in those bones. So it decreases the weight of those individual bones. The other thing it's going to do is it provides for resonating chambers for our voice. What we mean by resonating chambers is that, when you walk into a large room and you start talking, and the sound of your voice travels in that large room, your voice sounds much bigger than when you say walk into a small closet. So when we have these large open spaces that we find in these bones, as we speak and the sound travels out of our mouth, it also travels into our nasal cavities, and the sound bounces around in these paranasal sinuses, and it creates a larger, bigger sound for our voice. When we speak, we don't just speak with our mouth, we're speaking with our nose as well. If you hold your nose, okay, when you talk, you'll notice the significant difference in the sound and the loudness of your voice. Or when you have a sinus infection, you can hear the changes in your voice. All right, it's not as loud, it's going to sound kind of off or funny, and that's because those paranasal sinuses obviously get an increase in nasal mucosal production or infection, and that changes the shape of the paranasal sinuses, which affects your voice. The last thing that these paranasal sinuses are going to do is they are going to help to provide us with some protection. The mucosal membranes that are going to line the paranasal sinuses, as we breathe air in through our nose, the air is going to move around through these sinuses, and the mucosal lining is going to help to catch particulates and microbes that may be floating around in the air with us. All right. So they provide us some protection to all of the dust and particulates that float around us. Now, we won't necessarily see these sinuses on the models, so you won't have to label them specifically, but you should know what the sinuses are. And then fontanelles. Fontanelles are the soft spots that we see on newborn babies' skulls. All right. When a baby is born, they have incomplete cranial development. The cranial bones that are created from the intramembranous ossification process have not fully formed. So what we're left with is just the mesenchyme between the individual bones. And those are the fontanelles, or the soft spots that we associate with a newborn baby's head. Now, those fontanelles exist for a couple of reasons. One, it allows for some flexibility in the fetal skull, so that as the baby's head is passing, is passing through the birth canal, the baby's head can kind of adjust and change shape to the size and shape of the mother's birth canal. That's why oftentimes when you see newborn babies that were vaginal births, oftentimes after they're born, they kind of have maybe a little point or a little cone to the top of their head. That's because of the force and the pressure that's being put on their head by the uterus, and as they pass through the birth canal. That goes away typically very quickly because the suture joints haven't formed as well, so the bones are going to be able to reposition themselves into their original position after the baby has passed through the birth canal. The other reason that these fontanelles exist, and the lack of formation of the suture joints is the way that it is to allow for the rapid brain growth that we see within the first few months after birth. The first 3 or 4 months after a baby's born is going to be some of the most important times for brain development, which is why it's so important for us to expose newborn babies to as much as possible within those first few months after they're born. Look, there's a reason why baby toys are musical, they have bright colors, they're always moving, because we want to make sure that we're exposing all of the baby's sensory receptors to all of these different sensations, okay? That's why stuff that they have is fuzzy or is scratchy, or it has all these different things, because all the information that we are piling into this baby's brain is being cataloged, and it's growing new neurons at a very quick rate. And we want to grow as many neurons as we possibly can early in that development, because at a short period of time after we're born, our brain is not going to produce any more new neurons. All right. So it's important, again, to expose them to as much stuff as possible. And the fontanelles allow for this increased brain growth. We have multiple fontanelles. The anterior fontanelle is going to be the largest fontanelle. This is the one that's found between the frontal bone and the two parietal bones. And it takes the longest to close after birth. This is the one we kind of see right here, directly on the top of their head. The posterior fontanelle, okay, is going to be located between the parietal bones and the occipital bone, and it closes fairly shortly after birth, at about 2 months. We have two anterolateral fontanelles, okay, they're going to be located laterally, okay, and anteriorly, kind of in this area here. They're going to be where the frontal, the parietal, the temporal, and the sphenoid bones all meet. And then we're going to have posterolateral fontanelles, which are going to be located back here, and they're going to be where the parietal, the occipital, and the temporal bones meet. And we'll see that. We actually have a fetal skull model that we're going to take a look at, so we'll be able to identify those different fontanelles. All right. Any questions about that stuff before we get into identification? All right. So what we'll do is we'll go ahead, we'll take a look at those fontanelles that we see on the fetal skull first, and then we'll dive into the cranial and the facial bones. The last thing that we'll do is we will talk about the thoracic cage. All right, we'll identify the structures off of the sternum. I don't have a rib to show you, but I will talk about the ribs and give you the different parts of the ribs. And then we will do the vertebral column. All right, we'll talk about the different curves that are involved, and we'll talk about the different structures and the different that we see on these individual vertebrae. Now, when you get to the vertebra, you're not going to have to identify whether it's L1 or L2 or T3 and things like that. You'll just tell me that it's a lumbar vertebra, thoracic vertebra. The only specific identification with the vertebrae is comes in C1 and C2. That you do have to be specific about. All right, but let's talk about the fontanelles. And then last thing we'll do is we'll do the joints. So let me find my fetal skull right here. So we gave you a few views here of the fetal skull. One is kind of coming from the front and the superior anterior side. One is a true lateral view, and then the other is kind of this superior posterior view. So we have the bones of the skull also labeled on here, since we use the bones of the skull kind of as our reference points. So let's identify the bones of the skull that we see first, and then we'll go ahead and identify the fontanelles after that. So right here in the front is going to be the frontal bone. So that's what number 2 is pointing to. Then we're going to have 2 parietal bones. All right, we can see one right here. And then on the other side of that suture line there, on the right side of the skull, would be the other frontal bone. And we said that the anterior fontanelle we would find between the frontal and the parietal bones. So you can see the anterior fontanelle right there at number 1. Now we said that 6 right here, that's a parietal bone. Number 7 back here, that's going to be our occipital bone. And we said that the posterior fontanelle would be found at the junction of our parietal bones and the occipital bones. So that is our posterior fontanelle. And our temporal bone is going to be located right here, okay, almost right on the side of the head, right near the ear. So just anterior to the temporal bone, we're going to have our anterior lateral fontanelle, which is number 3. And then number 4, that would be where the posterior lateral fontanelle would be. All right. So we're going to have lots of different views of the skull, and I do recommend that you spend a pretty good amount of time practicing on the skull, because there are so many different views to it, and it does tend to get a little bit confusing because, you know, so many of the structures are, I don't say they're hard to see, but some of them, you know, it takes a little bit to kind of imagine, particularly since we're seeing these kind of as flat pictures. But I would, that's one of the things that the video kind of helps to do. It takes these flat pictures and it puts some depth to them. So yes, there are a lot of things on here. All right, we're going to have structures, we're going to have bones. Now remember, a lot of these structures are going to be bilateral, so we don't maybe have them labeled as being bilateral on here, but they may be bilateral. So when you give it on the test, you need to put left or right as it relates to the structure itself. So we're going to start up here, all right, because this is the easy bone. That's the one everybody wants on the test, and that is the frontal bone. That's number 1. Now, if it asks you to identify the structure, which is right here, kind of in the forehead region, that would be the frontal squama. Okay, the frontal squama essentially is your forehead. Now, number 3, and I wish that we could fix this picture. I keep talking to Mr. Russell about fixing this picture. If we could take this and draw this out along this entire ridge, but that's why I described this to you. If we could take that line and draw it along that whole ridge, that's actually what number 3 is pointing to. And that whole ridge is the supraorbital margin. Okay, so we have a supraorbital margin there, and we have a supraorbital margin here. Now, within that supraorbital margin, and you can see it better on this side, we do have an opening. Now, this opening is an opening that a nerve, blood vessel, ligament passes through. In this case, it's actually going to be a nerve, and it is the supraorbital foramen. So we have a supraorbital foramen on this side, and there would be one on this side as well. Number 4 is pointing to this bone at the posterior of the eye orbit. We can see it right there. We can see it back there. Now this bone we're actually going to see multiple places. Now there's only one of this bone. So even though you see it on the left and you see it on the right, you don't have to put left or right, because it's just one bone that goes all the way across the skull. But that bone that number 4 is pointing to at the back of the eye orbit, that's the sphenoid bone. Like I said, we'll see the sphenoid bone on multiple views. Right here in the corner of the eye, number 2 is pointing to a bone right there. This is one that you can actually see much better in the video. So when you watch the video, you'll hear me say that actually as well. It's right in the corner of the eye on both sides, and those would be the lacrimal bones. And then across the bridge of the nose right here, we have the nasal bones. Now, our cheekbone, okay, number 5, you can see it pointed right here. This is going to come out and then make up the lateral aspect of the eye orbit right there. So we've got one right there. We got one over there. That is the zygomatic bone. This opening right here that we have below the eye, if this up here was our supraorbital foramen, this down here is going to be the infraorbital foramen. Now we have a fissure right here and a fissure right here. These two fissures are called orbital fissures. So we're just going to name them based on their relationship to one another. Number 17 is the superior orbital fissure, and number 16 is the inferior orbital fissure. I need to go and put the circle on that. I don't know why it didn't stay on there. So superior orbital fissure, inferior orbital fissure. This is our nasal septum. The nasal septum is actually made up of two different bones. The superior part of the nasal septum right up here is coming from the ethmoid bone, and the structure part of the ethmoid bone is called the perpendicular plate. So if the label is pointing to the top half of this and says identify this structure, you would say perpendicular plate of the ethmoid bone. And the bottom half of the nasal septum here is just a bone called the vomer. Now you'll notice these little ridges of bone sticking out laterally from inside the nasal cavity. These are called nasal concha. So right here, okay, number 7 is pointing to, those are the inferior nasal concha. And then these right here, that number 14 are pointing to, those are the middle nasal concha. There is another set, but it's way up there, we can't see. Now, we have our lower jawbone here, which is one solid piece of bone. And then we have our upper jaw bones here, which are going to be two separate bones. The upper jaw bones are referred to as the maxilla, and the lower jawbone is referred to as the mandible. Now you'll notice these ridges, okay, that we see here that are forming the sockets for the teeth, all right? Those are called alveolar processes. Those are the bumps that we see along there. So the ones on the upper right here, those would be the alveolar processes of the maxilla. And these down here would be the alveolar processes of the mandible. Our chin, that region of our body is the mental region, okay? So this right here, our chin, would be the mental protuberance. And these two openings right here, because they are close to the chin, those are going to be the mental foramen. All right, so that is our anterior view of the skull. The next view we're going to do is our lateral view. Now on this lateral view, we can start to see some of our suture joints. On this skull, we did color the suture joints in so that you could see them a little bit more clearly because they got a little washed out when we took the pictures. But obviously in real life, those black lines are not there. So again, we have our frontal bone right here. This would be one of our parietal bones. That would be the left parietal bone. This would be one of our temporal bones. So that would be the left temporal bone. This right here, we said we saw already, that is our sphenoid. Now again, you don't have to put left or right sphenoid because it's just one bone that runs all the way across the skull. Now we said the suture joint that separated the frontal from the parietal bones is the coronal suture. We said the suture joint that separates the temporal from the parietal bones right here, that is a squamous suture. And then back here at number 15, we can just see the beginnings of the lambdoid suture. We'll kind of see the lambdoid suture a little bit better in just a minute. Or when you look on the video, I point to the lambdoid suture really well. All right, so let's identify some of the other bones, the facial bones, and some of these structures that we have here. All right, number 4, we said that that is our pair of nasal bones. Number 5, this is a bone we identified before. We said we couldn't see very well. That is the lacrimal bone. And at the base of the lacrimal bone right there is an opening, and that is the lacrimal fossa. This is our upper jawbone, or one of them. That is our maxilla. This is our cheekbone. That is the zygomatic bone. Now the zygomatic bone does have a process right here, okay? That process is connecting to the temporal bone. So we call this process on the zygomatic bone the temporal process because it's reaching out to connect to the temporal bone. On the temporal bone, we also have a process reaching out to connect to the zygomatic bone. So that would be the zygomatic process. Down here is our lower jawbone. That is the mandible. On our temporal bone, we have this large bony process right here. Number 13 is pointing to, and we'll see this guy a couple of times. That is the mastoid process. And then just anterior to the mastoid process, this opening right here, that is the external auditory meatus. That is basically your bony ear canal. Now a lot of these structures that we're talking about, and a lot of the structures that we talked about actually for the last lab, they're going to come in handy, the names of the bones and the names of the structures, when we get into the muscles. So when we start identifying the muscles and you start looking at the names of the muscles, you're going to see a lot of familiar things like names of bones and names of structures, because that's oftentimes how muscles get named. So there's a reason why we do these sequentially like we do, and there's a reason why we want you to learn them, because they help you learn them in the next section of material. All right. From our sagittal view, let's go ahead and look down on the superior part of our skull. Now this just gives us a little bit better view of the relationship of the frontal bones to the parietal bones. So we can see the frontal bone here and the coronal suture. You can see that squamous suture, how it's going to separate the left parietal bone from the right parietal bone. And then down here, this is the top half of our lambdoid suture. And then number 21 is the occipital bone. So again, that lambdoid suture is going to kind of be on the back of your skull, kind of upside down V like that. And it's going to separate two parietal bones here from the occipital bone, which is going to go under the posterior and the inferior of that skull. All right, so we have two other views of the skull. First, we're going to do the inferior view. Now, I have left a couple of things off of this inferior view on purpose, so if it's not labeled on here, the couple of things that I left off, then you don't have to know them. All right, number one, this is just pointing to our zygomatic bone. We see it from an inferior view. Now notice this inferior view is lacking the mandible, okay? We took the mandible off so we can see these structures more clearly. I had a question about that. They said, Dr. B, is there something wrong with that one skull? Well, that's anything wrong. We just took the mandible off so we can view all the structures. But this is the zygomatic bone from this view. This bone right here that makes up the hard palate, these are actually parts of the maxilla. All right, so this would be the left maxilla, this would be the right maxilla, but this structure of the maxilla is called the palatine process. Number two, right back here, that is pointing to the horizontal plate. Okay, horizontal plate is going to run right across like that. Number four is an opening right here behind these front teeth. These front teeth are referred to as incisors. So this is the incisive foramen. Now, number 7 and number 8, all right? You can see on here, number 7 and number 8 are pointing to these little processes of bone that we can see right there, okay? There's one there and one there. There's one there and there's one right there. Now, these processes, or sometimes they're called plates, these are called the pterygoid processes or the pterygoid plates. Now, pterygoid will give you fits to spell because it doesn't start with a T, it starts with a P. Okay, the P is silent, just like it is in pneumonia. We don't say pneumonia, okay? It's just pneumonia, so it's just pterygoid. So we have the medial right here, and there's another medial right here, and then we have the lateral one right here, and the lateral right there. Now, we have some openings here, okay, some different foramen that we're going to identify on this inferior view of the skull. The first one is this large opening that we see on either side right there. That is the foramen lacerum. So this would be the right, this would be the left. The next foramen that we have is this one right here, okay, and the other one we can't really see as well. It's kind of hidden right back over here. But this is the carotid foramen, or the carotid canal. You'll see it listed both ways. That is where the internal carotid artery is going to pass, which is going to keep your brain alive. And then the other foramen we have is this giant one right here, and that is the mental foramen. The foramen magnum. I had a complete brain fart there. The foramen magnum. Now, on either side of the foramen magnum, we have two condyles, okay? These condyles are part of the occiput, okay, or the occipital bone, okay? This is our occipital bone right here. So these are occipital condyles. At the posterior, right here, this little knot that we can see on the back of our skull, which you can feel if you reach back on the back of your head, this is on the occipital bone as well, okay? And it's a bump, which we call a protuberance. And because it's on the outside, it's the external one, because there is one on the inside as well. So this is the external occipital protuberance. Now, number 17, right here, okay, this is the mastoid process. We talked about the mastoid process before. So we saw it on that lateral view, but we can see it again right here. All right, that's the mastoid process. And just anterior to the mastoid process right here and right here, okay, this one's a little harder to see. Those are styloid processes. Now we have two other foramen that we can see right here. All right, there's another pair on this side right there. Number 18, this little dot of a hole we can see, that is the foramen spinosum. And then just anterior to it right here, and when we look on the inside of the skull, you'll see the shape a little more clearly. It's oval shaped, so that is the foramen ovale. And then the last thing right here, this is pointing to a bone that we identified that was the inferior part of the nasal septum. That again is the vomer.
All right. Did you say 18 was the nasal ovale or 19 is the
19 is the foramen.
Okay.
19 is the foramen ovale, and 18 is the foramen spinosum.
Okay. Foramen. All right. Thank you.
And then number 21 right here, number 21 is just pointing to this arch that's being created by our zygomatic process and the temporal process. So we call this entire structure right here the zygomatic arch. All right, one more view of our skull. And what we've done on this skull is we took our superior view and we took the top off the skull. So just to kind of orient you a little bit, this is the anterior of the skull and this is the posterior back here. So we can on the inside see the bones that we identified as part of the skull. This would be our occipital bone back here that number 8 is pointed to. Number 12, okay, on either side right there, that would be pointing to a parietal bone. Number 6 right here on this side and on this side, that would be pointing to temporal bones. And then in the middle right here, you can kind of see a butterfly-shaped bone, right? So if you watch me trace this right here, you can kind of see this butterfly shape right through there, all right? That butterfly-shaped bone is our sphenoid bone yet again. So I think he's got I think we have number 2 labeled as identify this bone, and that's just pointing at this butterfly-shaped sphenoid bone. And then the last bone we don't have it identified strictly as a bone, we just have the structures labeled to it. But we mentioned the ethmoid bone earlier, and this would be the top part of the ethmoid bone. Now, the ethmoid bone has some structures that we have labeled here. Number 17 is this little process of bone sticking straight up, and that's called the crista galli. Number 16, okay, which we see kind of bracketed right there, number 16 is pointing to this whole area of bone, okay? That whole area of bone is called the cribriform plate. And then in the cribriform plate, we have these tiny little holes poked in the cribriform plate. That's what number 1 is pointing to. And those are the olfactory foramen. Now, we said 2 is just pointing to the overall structure of the sphenoid bone itself. You can see, though, that we have a structure here in the middle of the sphenoid bone, and the bracketed part of that structure, which is this whole area there, okay, these 2 ridges of bone and the center, we refer to that bracketed part as the sella turcica. The sella turcica has a depression in the middle of it, okay, that depression right there is the hypophyseal fossa. That is where the pituitary gland is going to sit. Now, the sphenoid bone we described as being this butterfly-shaped bone, okay? You can kind of see the edge of it right there. It comes across. You can see the other edge right here. So just like a butterfly, the sphenoid bone is going to have wings. Okay, down here, number 5, this part right there, that part right there, that is pointing to the greater wing of the sphenoid bone. And number 15, right up here, okay, and on this side right here, that's pointing to the lesser wing of the sphenoid bone.
So the greater wing of the sphenoid bone is on the sides of the butterfly shape?
It's kind of, and again, when you see the video, it'll be a little easier to tell because, you know, I'm kind of turning the video and I've got a pointer that I'm showing you where it is. In this picture, you lose the depth a little bit. This is higher, okay? This ridge right here, this ridge of bone is higher, and this flattened out part right down here is kind of set underneath it like this. Does that make sense? So this whole flat area underneath here, that's the greater wing. And then there's a ridge of bone right up here above it, superior to it, that's the lesser wings. So the greater wings are down here, the lesser wings are up here.
Okay, I see what you're talking about now.
Okay.
Thank you.
Mm-hmm. Number 13 and number 11, all right, those are ones we did on our inferior view that I said would be a little easier to see on this view here. Number 11 is the foramen spinosum, and number 13 is the foramen ovale. Now on the video, you're going to see me identify another opening in this area here, and that's going to be the foramen rotundum, which we didn't label on the picture because we couldn't see really well, but on the video as I'm going through it, I show you where the foramen rotundum is. Number 9, this is the foramen magnum. Number 10, we have one right here. We have one on this side over here. That is the jugular foramen. And then number 7, we have one there and we have one there. That is the internal acoustic meatus. So we had our external acoustic meatus, which was on the outside of the temporal bone. This is on the inside. This is going to basically be the end of the ear canal. All right, any questions on the skull before we go to the mandible and the vertebra? All right, so let's do our mandible real quick. Mandible is pretty straightforward. We've actually done a couple of things on the mandible already. We said that these ridges right here, those were the alveolar processes. We said number 9, okay, even though we did it already once before, I don't know why it's not circled there. That is the mental protuberance. We said number 8 was our mental foramen. Now we do have another foramen, okay, back over here, kind of in the corner. That is the mandibular foramen. Now the mandible is basically made up of a few different parts, right? We have this right here, which is the ramus. We have this right here, which is the angle. And then we have number 7 right here, which is the body. Now, where the mandible attaches to the temporal bone is the joint called the temporomandibular joint, or your TMJ. This is what's going to go into the mandibular fossa that we find on the temporal bone. Okay, this is the condylar process. This piece of bone right here is going to be a site of attachment for a muscle. Okay, and that is going to be the coronoid process. Okay, just like the coronoid process that you had on the ulna, well, you have one on the mandible as well. And right here, this is going to be the mandibular notch. All right, let's do this. We're going to talk about the vertebra, all right? And you can see we have 5 different types of vertebra. We're going to start with our lumbar vertebra, and we're going to kind of work our way up the spine. Lumbar vertebra are going to be vertebra from L1 to L5. Okay, so we have 5 lumbar vertebra. We have 12 thoracic vertebra, and we're going to have 7 cervical vertebra, all right? In lecture, I talk about remembering how many you have at each level by remembering 7, then 12, then 5. Okay, and if you remember that at 7 o'clock in the morning, you drink coffee, which starts with a C. At 12 o'clock and at lunchtime, you drink tea. And at 5 o'clock, L, you drink liquor. So coffee at 7, tea at 12, liquor at 5. That's how you can remember how many there are of each type of vertebra. All right, so some of these vertebrae are going to have the same structures, all right? And so, you know, when we see a lumbar vertebra, we see a thoracic vertebra, they're going to have the basic, they're going to basically have the same structures. So I won't identify the same structures as we repeat from one to the other. What I'm going to do is I'm going to give you some kind of clues as to how you can identify a lumbar versus a thoracic vertebra. So when we look at this, I know it's a lumbar vertebra because it's going to have the largest vertebral body. Okay, and number 6 right here is the vertebral body, and that goes in the front. Number 1 back here, that is the spinous process, and that goes in the back. Each vertebra is going to have a vertebral body and a spinous process. There's only one vertebra that doesn't have those, and that's going to be C1. And all of the other ones are going to have a vertebral body and a spinous process. Every vertebra except for C1 is also going to have what we call transverse processes, which is what we have here and right here. And every vertebra will have an opening in the middle that the spinal cord or spine will pass through, and that is the vertebral foramen. So again, how do you know this is a lumbar vertebra? Because it has a very large vertebral body. That is the easiest way from this picture to tell that it's a lumbar vertebra. In the video, I go into some other explanations as to how you can tell, but this is the best way to determine on a picture. And you will see it differs from our thoracic vertebra significantly, okay, in the size of the vertebral body. Notice how much smaller the vertebral body is on the thoracic vertebra. Now, the spinous process on the thoracic vertebra tends to go a little bit more inferiorly. That's a little hard to tell in this flat picture, but that is pointing down as we look down on top of it. And then out here are transverse processes, which are a little bit larger on the thoracic vertebra. The reason they're larger is because each thoracic vertebra is going to get a pair of ribs that are going to come off of the body and attach or make contact with the transverse processes and then wrap around to the front of the body. So because there are 12 lumbar vertebrae, that will help you remember there are 12 pair of ribs because each vertebra has a pair of ribs. And then number 5 in the middle, again, that is our vertebral foramen. Don't worry about number 3 and number 4 on these. So that takes care of our lumbar and our thoracic vertebra, okay? So it's pretty easy to tell the difference between the two. Now we're gonna go to our cervical vertebra. And the cervical vertebra are gonna add something that we didn't see with the thoracic and the lumbar vertebra. When we look at the cervical vertebra, the first thing we can see is that we now have 3 foramen, all right? With lumbar and thoracic, we only had 1. It was right in the middle. That was our vertebral foramen. But now you can see we have 3 foramen, and all cervical vertebrae are going to have those 3 foramen. So these 2 out here are in the transverse processes, so they're called transverse foramen. Now, number 7, okay, that is our vertebral body. And number 8 is just pointing to those 2 transverse processes like we mentioned before. Now, another way you can tell the cervical vertebra is that their spinous process is typically bifurcated, okay, which means it has 2 points to it. So that is the bifurcated spinous process. You just have to put spinous process. I'm just pointing out that bifurcation. And number 2 back here, that is the lamina, all right? The lamina is part of what makes the vertebral arch on these vertebrae. So this vertebra here represents what we find in the vertebral column from C3 down to C7. Now C1 and C2, these are going to be specialized cervical vertebrae. And C2 we call axis. The reason it's called axis is because it's going to be the pivot point that we use to rotate C1 around it. So just like your tires on your car rotate around the axis of your car, the axle of your car, C1 is going to rotate around our axis. Now we still see some of our same vertebral properties. Okay, here's our vertebral body. Here are our transverse foramen. Here's our vertebral foramen. Here's our spinous process again. But notice on this C2, we have this large process of bone sticking up superiorly. All right, that's going straight up. That is the dens process. You'll see it sometimes written as the odontoid process, but I typically take dens process. D-E-N-S, easy to spell. And then sitting on top of axis is atlas. And atlas is C1. Now on the exam, you can either put C1 or C2, or you can put atlas or axis if I ask you to identify this bone. Now you'll notice atlas looks significantly different than did axis, all right? One thing you'll notice is we don't have a vertebral body. This is the front right here. There's no vertebral body because this is where the dens process is going to go for axis. So you can see the dens process would sit right there, and that vertebra then would rotate around C2. Now we still do have transverse processes. In those transverse processes, we do have transverse foramen. In the middle of the vertebra, we do have a vertebral foramen. Now we don't have a spinous process back here. Instead, we have a posterior tubercle. And in the front, right here, we have an anterior tubercle. This is going to be the anterior arch, and this is going to be the posterior arch. So we do have some different structures on Atlas. Now, right here, okay, number 5, this is the top side of our atlas. So this would be our superior facet. That's not labeled right. That should be the other way around. That should be the superior facet. And over here should be our inferior facet. But I'm going to take those off because I don't typically ask you about the facets, because it's too hard for you to tell the top and the bottom without actually having the vertebra in your hand. So I'm going to remove 5 and 6 when we get done with this. All right, any questions about the vertebra? Use the vertebral body size, use the number of holes that you have. That's how you can tell the vertebra apart. All right, the sacrum. The sacrum is basically where we're going to sit the vertebral column on. The sacrum is also going to be where we attach the os coxa on either side, okay, to create the sacroiliac joint. So we're going to look at the anterior of the sacrum, and we're also going to look then at the posterior of the sacrum. When we look at the sacrum has 2 different regions to it. It has the base and it has the apex. Now, base and apex don't mean what you think they mean. I know most of the time you think about base and you're thinking bottom. Base really means widest part, okay? And it happens to be the widest part on the sacrum is at the top. So number 2 is the base. And apex doesn't mean top, apex means point. So number 5 is the apex. We have openings here. These are the sacral foramen. And then right here on the front of the sacral base is the sacral promontory. And these little wings that we see out here on the sacrum are the sacral ala. Now, when we look at the posterior of the sacrum, the posterior of the sacrum is going to kind of look like what we see on the backside of the vertebra. On the backside of the vertebra, we saw spinous processes, and so what we see is a ridge of bone that runs down the back of the sacrum, and that's called the median sacral crest. We see our sacral foramen again. And then number 2 right here, that's pointing down into a structure right there where the spinal nerves are going to go, and that's the sacral canal. Now, where those nerves come out, okay, they come out at each level of the sacral foramen, but some of them are going to pass down to the coccygeal nerves, okay? The coccyx, your tailbone, would be right off the tip of the sacrum right there. And the opening where that comes out is called the sacral hiatus. All right, so let's take a look at our sternum. Now, this is our sternum with the costal cartilages, all right? Remember, the sternum is just the bony portion of it right there. And the sternum has 3 different regions to it, all right? This region right up here is the manubrium. This region here is the body. And the tip down here is the xiphoid process. Now, xiphoid is spelled with an X, not a Z. Connecting the manubrium to the body is the sternal angle. At the very, very top of the sternum, okay, we have this notch right here. That is the suprasternal notch. And then right there and right there is where the sternal end of the clavicle is going to articulate. And so that's the clavicular notch. So you remember when we looked at the clavicle, we said there was a sternal end. This is where it's going to sit, and then it goes out laterally and it articulates out there with the acromion on the scapula. Now, these costal cartilages are going to attach 10 of our 12 pair of ribs to the sternum, all right? 2 of our ribs do not attach to the sternum. Those are what we call our floating ribs, okay? And they're going to be coming off of T11 and T12. But the other ribs that we have all are going to articulate with the sternum. Now, we're going to have 7 pair of ribs, okay? These first 7 are pieces of cartilage, okay? We see right there, 1, 2, 3, 4, 5, 6, 7. Those are called the costal cartilages of the true ribs, okay? They're classified as true ribs because each one of these pair of ribs has its own individual connection to the sternum. Okay, so ribs 1 through 7 are the true ribs, and these are the costal cartilages of those ribs. Ribs 8, 9, and 10, okay, you'll see they all join together, and they're going to merge and connect via one piece of cartilage, and those are the costal cartilages of the fake or false ribs. So we have true ribs, we have false ribs. Any questions on the sternum or any of the axial skeleton before we get into the knee joint?
The ribs, I'm a little confused. Like you said, the true ribs are attached to that cartilage,
right?
And the false ribs are not. But
no,
I can't.
The false ribs attach to cartilage. It's just the way the cartilage then attaches to the sternum. These true ribs each have their own individual connection. Right? Okay. The false ribs
are like connected together.
They all merge together and they're going to share one connection. So like this one, this one, this one, they connect right there and connect as one piece of cartilage. Does that make sense? But the true ribs, they get a direct connection to the sternum.
Okay, I understand. Thank you.
Okay. All right. Let's now then take a look at our knee joint. All right, we're going to take a look at a few different views here. We'll start anteriorly, and you may hear some terms that you may have heard before. So first of all, we have to kind of figure out if we're looking at a right knee or we're looking at a left knee. And the way to figure out if we're looking at a right or a left is to look at the relationship here of the fibula compared to the tibia. We know the fibula is lateral, so this is a right knee joint. All right, does everybody see how to figure that out? How do I know it's anterior? Well, I know it's anterior because of the patellar tendon right here, which is number 4, and the quadriceps tendon, which is right here, number 1. So that tells me this is the anterior side, this is lateral, so that tells me this is right. So we have 2 primary ligaments, okay? One is going to connect the femur to the fibula. The other is going to connect the femur to the tibia. This is on the medial side. This is on the lateral side. So number 6 right here, that is your lateral collateral ligament. And number 2 right here, this is your medial collateral ligament. Now you may remember when we talked about tissues, we talked about fibrocartilage, and we said fibrocartilage can be found in the menisci of the knee. Well, here is our medial meniscus, And just right there, that little piece is our lateral meniscus. Now we'll see the menisci a little bit better in a second when we open the knee up, and you'll kind of see the shape of the individual menisci. Let's look at this posteriorly, okay? Because we don't see a patella in the way, and we don't have those tendons in the way, so we can see a little bit more of the ligamentous parts of the knee joint. So again, this is still a right knee. We're looking at this from behind, okay? Our fibula here is lateral. This is our lateral collateral ligament, and that's our lateral meniscus. That's our medial collateral ligament. That's our medial meniscus. And then this is one of what we call our cruciate ligaments. We have two cruciate ligaments. We have an anterior cruciate ligament. We have a posterior cruciate ligament. This happens to be the posterior cruciate ligament. Now we can see this torn ligament right in there. That actually is the anterior cruciate ligament. So that's your PCL, and then that torn part right there would be your ACL, which we're going to look at in just a second. So when you hear about athletes with a torn ACL, that's what it is. So because our poor knee that we have on the West Bank has had some serious knee injuries with its torn patellar tendon, I decided to go ahead and open it up here so you could actually see what the menisci looked like. So we're looking down on the top of this right knee. So again, this is our lateral collateral ligament here. This is our medial collateral ligament. This is our medial meniscus. Okay, notice they're kind of horseshoe-shaped discs. That's to provide a little lateral stability to the femoral condyles as they sit down on that those tibial condyles. This is our lateral meniscus. That's our intact posterior cruciate ligament. And then right here, you can see the torn anterior cruciate ligament. Okay, and it's torn off right there. So this poor individual is going to have to undergo major reconstructive surgery, and they are not going to be playing sports for about a year. Any questions?